The continued hormonal function of the ovaries after menopause has been well established, and the current understanding of the health-related long-term effects of removal of the ovaries has affected a change in the indications for oophorectomy, while adnexectomy is presently indicated for women with an adnexal mass suspicious for cancer, increased risk of ovarian/tubal cancer due to genetic mutations, or for some women with severe symptomatic endometriosis. Conservation of the ovaries should be considered for most other women without these conditions. Prophylactic oophorectomy in order to prevent the subs. Women having normal ovaries removed at the time of hysterectomy for benign disease every year, and subsequently confirmed, showed that the ovaries continue to produce androgens which are converted to estrone throughout a woman's lifetime. Constructed from previously published studies, this model suggested that the health benefits of ovarian conservation outweighed the very small risk of ovarian cancer. In 2013, an analysis of the Nurses' Health Study cohort examined health outcomes after 28 years of follow-up for 16,873, 56.3%, women who had a hysterectomy with bilateral oophorectomy for benign disease, and 43.7%. women who had a hysterectomy with ovarian conservation. Although oophorectomy was associated with a much lower mortality from ovarian cancer, less than 1% of the women with ovarian conservation died of ovarian cancer. In contrast, more women who had bilateral oophorectomy died from lung cancer. HR equals colorectal cancer, total cancers, and coronary heart disease when compared with women who had ovarian conservation. Importantly, at no age was oophorectomy associated with an increased survival. Studies from the Mayo Clinic had similar findings. Women who had bilateral oophorectomy before age 45 had a 44% increased risk of cardiovascular mortality. Other Mayo studies showed higher risks of anxiety/depression, dementia/cognitive impairment, and Parkinsonism in women who had their ovaries removed. In addition, after oophorectomy, about 90% of premenopausal women will have vasomotor symptoms, and many women will also experience mood changes, a decline in well-being, a decrease in sexual desire, sleep disturbances, and headaches. Additionally, vaginal dryness, painful intercourse, bladder dysfunction, and symptoms of depression may occur. In both the NHS and Mayo studies, these detrimental effects on health outcomes were not seen in women who took estrogen following oophorectomy. Therefore, some gynecologists have suggested that oophorectomy be performed at the time of hysterectomy for benign disease, and these women be given prescriptions for menopausal hormone therapy and statins to ward off harmful cardiovascular effects. But studies show that within 5 years of a first prescription, only 17% of women continue to take estrogen, and fewer than 18% are still taking statins, 11. And these numbers are overstated, since they do not include women who never see a doctor but don't get a prescription, or women who get a first prescription but never fill it. Consequently, removing ovaries and prescribing medication to prevent the health consequences is not likely to be effective. Medical ethics suggests that prophylactic procedures should follow 2 guidelines. There is a reasonable expectation that the procedure will result in a net benefit to the patient, and, without the intervention, the individual would bat high risk of developing the disease. Therefore, the evidence suggests that removal of healthy ovaries does not meet the definition of a prophylactic intervention. Therefore, prophylactic oophorectomy, in women at average risk of ovarian cancer, should be approached with caution. Tubal cancer and salpingectomy. Recently, the origin of epithelial ovarian cancer has been questioned. Interestingly, the ovary contains no epithelial cells, and metaplasia of surface Müllerian cells to epithelial cells has been hypothesized to explain the types of epithelial ovarian cancer: serous, mucinous, and endometrioid. Recently, with careful pathologic analysis of ovaries and tubes removed from BRCA-positive women, precursor lesions called serous tubal intraepithelial cancer, STC, have been found in the fallopian tubes, but no such precursor lesions have been found in the ovary. STC lesions have the same p53 mutations found in high-grade serous ovarian cancers. The more indolent and treatable stage I low-grade cancers, found rarely inside the ovary, do not have these p53 mutations. Astonishingly, the deadly form of ovarian cancer does not come from the ovary. Most aggressive ovarian cancers are, in fact, tubal cancers. Bilateral salpingectomy has been proposed as an alternative to oophorectomy, as it removes the source of aggressive cancers but conserves functioning ovaries. Interestingly, a recent study found that women having hysterectomy and salpingectomy had similar sonographically measured antral follicle counts, mean ovarian diameters, and similar blood levels of AMH and FSH. Therefore, it appears that the ovaries function normally after salpingectomy. Based on all of the evidence, and following the lead of the Society of Gynecologic Oncologists of Canada, the Society of Gynecologic Oncologists recently published practice guidelines suggesting that for women at average risk for ovarian cancer, salpingectomy should be considered at the time of hysterectomy, in lieu of tubal ligation, and also at the time of other pelvic surgery, after completion of childbearing. This strategy is being closely studied in Canada. It appears that there is now a convergence of ideas. Aggressive ovarian cancer appears to be tubal cancer, and salpingectomy may prevent many of these horrible deaths. Oophorectomy has adverse long-term health consequences for women, and ovarian conservation should be encouraged. Oophorectomy not indicated for most ovarian cysts. Benign ovarian cysts are a common finding in women. In asymptomatic women aged 25 to 40, 8% are found to have ovarian cysts larger than 2.5 centimeters, and a study of women age 50 or older found 18% had unilocular cysts less than 10 centimeters. However, most ovarian cysts will resolve, even in postmenopausal women. The University of Kentucky ovarian cancer screening program monitored women with baseline and subsequent transvaginal ultrasonography. Over 25 years of follow-up abnormal sonograms were found in 6807 women, 17.3%, over this time. Ovarian cysts were commonly found in premenopausal women. The prevalence was 34.9% and the incidence was 15.3%. In postmenopausal women the prevalence was 17% and the incidence was 8.2%. For the group having an initial abnormal transvaginal sonogram, 63.2% resolved on subsequent sonograms. The abnormal findings were classified: unilocular cysts, 11.5%, cysts with septations, 9.8%, cysts with solid areas, 7.1%, and solid masses, 1.8%. Surgery was performed on 557 women with the findings of 472 benign cysts and 85 ovarian malignancies. Serial sonography found that many ovarian abnormalities resolved, even if the initial appearance is complex, solid, or bilateral. Cysts considered low risk for malignancy, unilocular and cysts with septations, had a median time to resolution of 12 months. Interestingly, cysts considered higher risk for malignancy. Cysts with solid areas or predominantly solid masses had a shorter median time to resolution, 2 months. Although many cysts resolved in less than 6 to 12 months, some cysts took longer and, when documented to be stable, these cysts were then followed on an annual basis. However, after 6 to 12 weeks, cysts that increased in complexity or size were more likely to be malignant, and the authors recommended surgery. 15. Using this strategy of serial sonographic monitoring was associated with a positive predictive value of 25%. Therefore, the authors recommended avoiding a single sonographic abnormality as the sole indication for surgery. And they recommended using serial sonograms to reduce false positive results and unnecessary surgery. When evaluating women with an adnexal mass, it is a good idea to view the images yourself. Many radiologists use the descriptive term, complex, to denote any cyst other than entirely clear simple cysts. However, complex cysts include many benign etiologies, dermoid cysts, endometriomas, hemorrhagic cysts, and cystadenomas. Very young women are at risk for developing germ cell tumors, which may produce BHCG or alpha-fetoprotein, so these tumor markers should also be considered. Tumor markers, such as CA-125, are rarely helpful in determining the management of cysts in premenopausal women since the chance of a false positive is about 70%. Endometriosis, functional cysts, fibroids or adenomyosis, cyclic elevations associated with the menstrual cycle, pelvic infection and pregnancy, all common conditions in premenopausal women, have all been associated with abnormally high values. Also, 50% of women with stage I ovarian cancer will have a negative test. Therefore, this test should be avoided in premenopausal women. Careful scrutiny of the images and serial sonography will often be indicated, and, at times, other imaging studies can often help determine the most likely diagnosis and help guide management. Suspected dermoid cysts can often be confirmed by limited CT scan, when fat, sebaceous material, teeth or bone is seen within the ovary. If a hemorrhagic cyst is present, a follow-up sonogram about 2 weeks later may show either a smaller cyst or changes in the internal echoes consistent with organizing clot. One study showed that surgery for adnexal masses found during cancer screening does not decrease the death rate from ovarian cancer and subjects some women to the risks of unnecessary surgery. The prostate, lung, colorectal and ovarian cancer screening randomized controlled trial randomized women ages 55 to 74 to a study group screened with annual transvaginal ultrasonography and a control group who received usual medical care. 16. The women were followed for 11 to 13 years and managed based on the findings. In the study group, 212 women were found to have ovarian cancer and 118 women died from ovarian cancer. In the usual care group, 176 women were found to have ovarian cancer and 100 women died from ovarian cancer. The risk of death was statistically no higher in the screened group. Mortality. These women, 15%, had at least one serious complication occur as the result of unnecessary surgery for an adnexal mass detorsion rather than adnexectomy. For adnexal torsion, especially in premenopausal women, detorsion of the adnexa, even in apparently severely injured ovaries, can be accomplished with good recovery of ovarian follicles and hormonal function. The not infrequent black-blue appearance of a torsed adnexa results from venous and lymphatic stasis, but some blood supply continues from the ovarian or uterine artery. Some studies suggest that time from the onset of pain to detorsion best predicts viability of the ovary. 1 study found evidence of necrosis on microscopy only after 48h following the onset of pelvic pain. 18 young women, ages 23 to 35, undergoing in vitro fertilization and ovarian stimulation, were studied with sonography following detorsion of the adnexa. 19. There was no difference in mean antral follicle counts when the detorsed ovary was compared with the contralateral ovary at 6 months following surgery. Due to the edema caused by torsion, some authors recommend detorsion of the ovary and postoperative follow-up. with serial ultrasounds to determine cyst resolution. 20. Cystectomy at time of detorsion may be difficult due to the edema and loss of tissue planes. Additionally, one study found that in 3 of 4 women treated with cystectomy at the time of detorsion, loss of ovarian function was found in follow-up sonograms 6 months later. However, if the cyst is not removed, there is risk of retorsion and need for another operation. One study found higher rates of recurrence among 40 women managed with detorsion and cyst aspiration, compared with detorsion with cystectomy or salpingo-oophorectomy. Malignancy is present in 2% of women with adnexal torsion, and oophorectomy should be considered in postmenopausal women. However, in pre-menopausal women, detorsion and ovarian conservation should be strongly considered. When adnexectomy is warranted, oophorectomy is indicated when the mass is considered suspicious for a neoplastic lesion. Criteria for suspicious lesions include a high initial morphology index, increasing size or complexity on serial sonography over a 6 to 12 week time period, or an elevated UKI developed a morphology index MI in a cohort of postmenopausal women, which can be helpful in predicting the likelihood of malignancy for ovarian tumors. The MI calculates a score between 0 and 10, using sonographically determined volume and morphologic complexity, with complexity having twice the weight of volume. A score of 0 to 4 implies that the cyst is likely benign. Implies that the cyst is likely malignant. 85% of all cancers had a MI score greater than or equal to 5. The risk of malignancy based on the calculated MI was the best predictive values for malignancy were achieved with serial sonographic evaluation at 6 to 12 week intervals. The mean increase in MI for tumors found to be malignant was 1.6 per month. Women who were found to have benign tumors at surgery had a mean decrease of the MI of -0.3 per month. Tumors that resolved over time had a mean decrease MI of -1.0 compared to tumors subjected to surgery. This study is very helpful to show that most ovarian tumors, even those with morphologic complexity, resolve over time. However, tumors that have an increase in MI over time should be considered for surgical exploration, oophorectomy, frozen section and surgical staging if malignancy is found. Women with BRCA1 have 40% risk of having ovarian cancer in their lifetime and confers a 20% lifetime risk. Women with mutation have an increased risk of ovarian/tubal cancer as early as age 35, and 2 to 3% of these women will develop ovarian cancer by age 40. The risk of women with the BRCA2 mutation developing ovarian/tubal cancer occurs about 1 decade later. Women with Lynch syndrome, especially those with the MSH2 gene, have a lifetime risk of ovarian cancer of 33%, and they also have a 40 to 60% risk of developing endometrial cancer. In a BRCA-positive woman, oophorectomy, or more correctly, adnexectomy, reduces the risks of ovarian/tubal cancer to less than 3%. Current recommendations suggest adnexectomy at the completion of childbearing or 4. Before age 35 to 40 before age 50, 4. Lynch syndrome, adnexectomy and hysterectomy before age 40. Endometriosis and oophorectomy. For women with severe, symptomatic endometriosis unresponsive to conservative management, bilateral oophorectomy concurrent with hysterectomy may decrease recurrent or persistent symptoms and the need for reoperation. 25. One study of women with symptomatic endometriosis compared outcomes between women who had a hysterectomy with ovarian conservation and women who had a hysterectomy with concurrent bilateral oophorectomy. For the women who had ovarian conservation, 62% had recurrent pain and 31% required reoperation. For the women who had both ovaries removed, 10% had recurrent pain and 4% required reoperation. Another study of women with endometriosis found that of the 47 women who had a hysterectomy with ovarian conservation, 19% required further surgery over the 7 years of follow-up. Of the 50 women who had a hysterectomy with bilateral oophorectomy, only 8% required reoperation. Preservation of both ovaries doubled the risk of reoperation regardless of the patient's age. Nevertheless, given the problems associated with early menopause, the authors recommended that for women younger than 40 years, hysterectomy with ovarian conservation should be considered. Large masses. Some women may be symptomatic from larger cysts, or they may not be comfortable with, or available for, close follow-up. For these women, surgery may be indicated. There is some evidence for removal of endometriomas, that ovarian function decreases after removal of cysts greater than 4 cm when compared with cystectomy for cysts smaller than 4 cm, 28. However, a review of the literature found no studies show